goes through life, one accumulates or picks up a variety of environmental and genetic and social factors that impact a person, that change a person. And dementia is no different as something that doesn't just happen at the end of one's life, but really is an accumulation of something that occurs throughout one's life. I tell our residents sometimes I like to talk about this as a karmic backpack. Is the backpack that we carry through our lives that impact who we are as a person and what diseases or what healthy behaviors we manifest. So in dementia, this is from a review in the Lancet several years back from a variety of experts who work in the dementia field. There are numerous risk factors, including genetic risk factors early in life. Education impacts risk of dementia in future life. In midlife, hearing loss and hypertension, as well as obesity, seem to play as a risk factor for dementia, largely, most likely mediated through small vessel disease and stroke pathologies. And then late in life, a variety of other things, smoking, physical inactivity, social isolation, all also impact an individual's risk to develop dementia. Many of these risk factors for dementia, as seen here on this slide, are actually quite modifiable. When you hear me say hypertension or smoking or social isolation or physical inactivity, these risk factors are readily modifiable, or at least there's a possibility of modifying these risk factors as opposed to a genetic risk factor that one is truly one truly lives with. Reversing these things, of course, much easier said in the consultation room than actually done in real life, but it is something that we can strive for as physicians to try to impact and help our patients. So as you guys all know, there's a variety of different risk factors that lead to dementia. Alzheimer's disease is one of the big ones. The underlying pathology associated with Alzheimer's disease is thought to be due to amyloid plaques and neurofibrillary tangles that cause changes in the neurons, which result in degeneration of the hippocampus and temporal areas, and then spreads to a variety of different parts of the brain over time. An Alzheimer's disease brain is significantly more atrophied as compared to the normal brain, shown here on the left. Beyond Alzheimer's disease, though, cardiovascular disease has also affected memory in many patients, and that's been more recently shown. But the reason why Alzheimer's disease and dementia in general is more seen now, why we have to deal with it much more commonly than perhaps we did 50 years back, is that cardiovascular death has been dramatically declining. Numerous studies have really shown that really an exponential or near exponential decline in both cardiovascular disease, and cardiovascular disease associated mortality. Stroke itself has also gone down, and largely this is probably due to just better prevention as well as treatment of hypertension, which was really a big gain for the medical professionals in being able to have significant amount of medications to reduce blood pressure, which invariably increases in older individuals. And then also lifestyle modification and the way our society is now built in Western developed societies. Cardiovascular risk factors seem to also have been reduced. these other societal factors are, of course, beyond our control or medicine's control, but there's some evidence I'll show at the end that seems to suggest that even controlling for the medical interventions that we do, the unknown variables that seem to be reducing cardiovascular death are strongly present. And so the society, as the society changes and the societies become healthier, cardiovascular death has decreased, and dementia outcomes has increased. There are a variety of different causes for stroke, as many of you guys know. Both small vessel and large vessel disease is what we tend to break it up in our hospital when we talk about it with our fellows and residents. The small vessel disease is what we're most interested in our group due to atherosclerosis and due to cerebral amyloid angiopathy, which affects small blood vessels in peripheral areas of the brain versus deep structures that are implicated in atherosclerosis. Large artery lesions also can cause strokes, atherosclerosis in the carotids or the basilar artery, as many of you know. These, of course, manifest in a variety of different MRI findings that now are commonplace. But at the time, 25 years back, when SWR, GRE sequences were first being developed, this was really an eye-opener, as it were, to diagnose cerebral amyloid angiopathy. These microbleeds that you see in cortical areas is from one of our patients that clearly are in cortex and subcortical regions and strongly associated with cerebral amyloid angiopathy through pathologic studies that we've done over several decades. So the MRI visualization of small vessel disease, not only microbleeds but white matter hyperintensities, really opened up this field of VCID for study. Prior to this, it was all conjecture as to what was going on in the brain. Was there Alzheimer's pathology? Was there stroke? You would never really know until the patient came to autopsy, which by then it was a bit too late. But for an academic interest, it was quite good, but it didn't actually bring anything to the bedside or didn't open the possibility of therapeutic intervention. So the MRI and technological advances really opened up the field to really new innovation and new ideas for treatment. So vascular lesions independently contribute to dementia. This work is from Julie Schneider's group and David Bennett's group in Chicago, the Russian Memory and Aging Study. And Julie's nicely shown that while Alzheimer's disease pathology contributes to dementia in a large cohort of subjects that were studied both during life and at pathology, both macroscopic stroke-related infarctions, as well as microinfarctions, small areas of tissue infarction that is not visible on classical clinical MRI sequences, as well as amyloid angiopathy, have an independent effect on association with dementia. And so this idea that small vessel disease is one paper that really, among many, that really suggests that stroke and small vessel disease contribute to dementia risk in elderly individuals. Microbleed location in amyloid angiopathy is quite important, as I alluded to. This is another example of one of our patients from one of our reviews a while back, one of our pathologic studies a while back, suggesting that microbleeds in cortical areas specific for amyloid angiopathy, while microbleeds in deep areas more commonly associated with vascular risk factors such as hypertension and diabetes, as well as atherosclerosis. And so this was our way to distinguish amyloid angiopathy patients from other patients. And it was really a way to purify our cohort to study people with so-called pure amyloid angiopathy, whatever that means. I'll nuance that a little bit, hopefully, in this talk. But it doesn't mean that patients with deep microbleeds can't also have lobar microbleeds. That exists. These mixed cases also exist, and we've reported on that. But these pure cases without any hypertensive disease have really been the basis for our studies of our group over the last 10 to 15 years. So microbleed location in MRI, on MRI is also quite characteristic in CAA. This is an old illustration from one of our old papers, suggesting that microbleeds really are located in posterior areas of the brain compared to frontal areas. And that goes with the pathology seen in amyloid angiopathy that is focused in posterior areas when examined on autopsy. So Suzanne Van Velo in our group, she's a Dutch neuroscientist who's now faculty at Mass General and Harvard, is a spectacular colleague and investigator who is looking to correlate the MRI findings seen in life with the pathologic findings found at autopsy. And Suzanne's done some really, really nice work, really a body of work in her group, looking at these questions: how microbleeds match to pathologic examples of the same tissue after a patient passes away, and then she's also looked at questions like what is white matter disease in patients, and has looked at white matter changes in the brain, and then examined these areas in detail at autopsy with histopathology. And so Suzanne's work has really, for us, validated or reconfirmed a lot of the MRI findings that we're seeing, such as microbleeds, are in fact small areas of bleeding seen in the cortex, as shown here, that can be visualized in life. In life during a patient's lifetime. So this confirms to us that what we're seeing is actually what we're treating, because oftentimes this is a question in some of these MRI imaging studies, is that the MRI may be visualizing something, but how do we know it really correlates with what is happening at the pathologic level? So I alluded to this idea of microinfarctions from Julie Schneider's work, suggesting that microinfarctions seen at pathology impact cognition. Microinfarctions are another small vessel disease lesion, and these microinfarctions, not surprisingly, correlate with other small vessel disease lesions, such as microbleeds. Arnie Lauer, who is a radiologist, a German radiologist now based in Frankfurt, one of our old fellows, nicely showed here that cerebral microinfarctions seen on pathology are visible, clearly associated with MRI visualized microbleeds. So an individual with numerous cerebral microinfarcts seen at tissue pathology, when you go back and look at their in vivo or during life MRI, you see those individuals have many more cerebral microbleeds. And so small vessel disease pathology does not seem to be isolated, but seems to come in groups. All of these lesions do seem to correlate with each other. So this is what we call the so-called CAA signature of neuroimaging-based markers of amyloid angiopathy, but this is kind of more generalizable to all diseases of BCID, probably in different proportions. Again, just to reemphasize, I think really the only reason we study CAA is that we can identify it. You know, this is maybe some mentoring advice for people, for young trainees going into research and going into medical translational research. We really kind of study what we can see is really the bottom line, and that's always good to keep in mind. And what we can see, we always need to correlate that to the patient. So that these are the two really important things that really, I think, make a good career in whatever field you choose. For our example in CAA, you know, the microbleeds came second, right? So the first thing we were really interested in amyloid angiopathy were the intracerebral hemorrhages, and that's the thing we saw, right? Patients coming into our hospital with large lobar hemorrhages, and they kept coming, right? So we were kind of interested. Some of my colleagues were quite interested in why this was happening, and that's how we got to study these patients. So really starting with the patient is really the key lesson here. So the so-called CAA signature associated with microbleeds, white matter hyperintensities. You can see the white matter hyperintensities here in posterior regions, and then you see dilated peривascular spaces in higher cortical areas is quite common in CAA. And then the most recent neuroimaging marker that we've seen in CAA is superficial siderosis, or really sulcal bleeding events that initially can be acute. They can be visualized on CT scan, but then over time they develop into these chronic hemosiderin-based deposits in the sulci. These individuals with this type of bleeding are at higher risk for future stroke events, intracerebral hemorrhage events, and that's been shown by a variety of our colleagues who've worked in our group and who now are independent investigators working in this field. So vascular pathology in the brain leads to cognitive impairment and dementia. That's the intuitive first step. But then vascular pathology in the brain can also lead to symptomatic stroke, right? So that's a whole different field where people are looking to try to understand how individuals with existing vascular pathology in the brain, why they have an increased risk for symptomatic stroke. It can also lead to subjective memory complaints. It can lead to what we call transient focal neurologic deficits, or TFNEs. These are TIA-like syndromes where patients develop almost an epileptic type marching change in sensation or weakness or language deficit or confusion that is transient in origin. It appears to be more epileptic-like, but is not epileptic in nature, which can occur presumably due to vascular pathology associated with the microbleeds and microinfarctions in cortical areas in small vessel disease and CA specifically. And then finally, the most important one, vascular pathology in the brain can cause no symptoms. That's the denominators, what we like to say in epidemiology, right? So the patients, or those are the people that we never see, that never come to medical attention. So they're not patients. So we don't know how big that denominator is, but it's pretty big if you look at studies like population-based studies, like such as the Framingham study or the Rotterdam study. These studies really do suggest that there are numerous people with vascular risk factors that really are totally normal. They have clinically normal, and then they never change over a 10 or 15-year follow-up. So that denominator is quite large, and it's also something to keep in mind for us as clinicians, because that really puts some of this into perspective. So we recruit these patients from a variety of different places. We recruit and study them in a variety of different places. Subjective memory complaints and the cognitive impairment and dementia come from memory clinics. Stroke clinics are the ones that that are able to find patients with symptomatic stroke and transient focal neurologic deficits. And then patients with no symptoms, we study in population-based studies, such as the Rotterdam study, with which we work very closely with our colleagues in the Netherlands. So, and then there's this whole other area about what risk factors lead to vascular pathology in the brain. And I'll talk a little bit about that related to hypertension, which I think is probably the most important vascular risk factor around, not only for CAA, but for cardiovascular disease and for life in general. When we treat hypertension or really get to the origins of why individuals are hypertensive, a lot of these other things such as diabetes, atrial fibrillation, obesity tend to go away. So I think it's a good, from a clinical point of view, I think it's a good place to start. But all of these risk factors do lead to vascular pathology in the brain, and how to stop that or how to intervene there is something else. I think is an important, real clinical problem that should be addressed in future years. So CAA pathology is very common in healthy individuals, much like the previous slide alluded to. Both the Rotterdam study and another population-based study based in Iceland called the Ages Reykjavik study have suggested that microbleeds are really, really common, as shown here in the Rotterdam work. In the Rotterdam work can be up to 17 to almost 40% of individuals who are older in the highest age group can manifest microbleeds in cortical areas. So CAA is quite common, but again, most of those individuals with identified CAA in population-based studies never come to medical attention and are never symptomatic. So much like Alzheimer's disease pathology, there's a large percentage of people in the population that have Alzheimer's disease pathology, but do not have disease. And again, so it's something else that I like to distinguish in our teaching and our research, is that there's a big difference between what we can see pathologically, what we can see on MRI, and then what the patient actually, who the patient is. And so the MRI is meaningless without the patient. So that's really important to remember. Something that we oftentimes forget in the rush of, certainly in our hospital, with the rush of technological advances and the easy Amazon-based clicking of ordering MRIs and any study under the sun, we oftentimes forget about the patient who's usually saying, "Hey, I'm over here." It happened before with the stethoscope, and now it's happening again with neuroimaging and other laboratory tests. So that's really important for, I think, for all of us to remember as clinicians. Microbleed numbers are also important. Our CAA work shows that individuals with numerous single microbleeds, for example, in the Rotterdam study, those individuals tend to really manifest no symptoms and never really have any troubles. Whereas individuals who start out like this with numerous microbleeds in a population-based study invariably do have a different outcome. They develop cognitive impairment or have other different types of stroke outcomes. So that's also important to keep in mind. So it's not black and white, but there is really a grading here in all of these diseases. So I'm going to show a little bit of work from the Rotterdam study because I think it's really, really nice. This is Salwa Akadad's work, my colleague. She's a neurologist now in the north of Holland and trained during the Rotterdam study. Trained in the Rotterdam study. Subjects with individuals with more than 4 microbleeds in the Rotterdam study were at increased risk of cognitive decline, which is quite striking, and it goes with this idea of dosing of small vessel disease. So the higher amount of small vessel disease you start with, the higher risk that you have of developing future cognitive impairment. And Salwa nicely showed that individuals with in this higher tertile, greater than 4 microbleeds, had impacted their executive function, their memory, and information processing. Again, much like we hear about on board tests about vascular-related dementia, they have impairment in information processing, executive function. So something something that I thought was quite notable. And then beyond Salua's work, back to David Bennett and Julie Schneider in Chicago, they've nicely shown that beyond small vessel disease, CAA and others, there's a lot of other pathology in dementia brains. So not only does Alzheimer's pathology occur, Alzheimer's pathology and CAA occur frequently together. And then other pathologies such as atherosclerosis, macroinfarcts also occur in the brain, are actually quite common. The frequency, as you can see, of these combined pathologies really represent the majority of patients that they've seen in the Rush memory and aging study. But the combination of these pathologies is multiple. And so it's also important to remember, and also just makes us a little bit more humble about what we're discovering and what we're not. Is that while CAA may have an independent impact on dementia, it certainly doesn't explain everything, and certainly probably is not the cure-all solution for dementia in the elderly. It's just something to keep in mind when we go through and discover these things slowly in the complex physiology of the brain. So we've done some other stuff associated with this dosing idea of more microbleeds or more small vessel disease is associated with worse outcomes. Andres Jaimidou in our group now is a fellow at Boston University, devised this very nice small vessel disease score in CAA, and there's been other small vessel disease scores in other small vessel diseases that is really a way to try to characterize the burden of small vessel disease. Andres built this score around number of microbleeds, the frequency or dissemination of superficial siderosis, as well as the presence of white matter hyperintensities and perivascular spaces. And Andres actually showed that with these vasculopathic changes on pathology was strongly associated with the SVD score that he constructed. So that is to say, the more burden that an individual had, the higher small vessel disease score that an individual had on neuroimaging. When Andreas looked at these at pathologic examination, those individuals had much more pathologic-based vasculopathic changes. And those individuals were also at greater risk of developing intracerebral hemorrhage. And so this visual measure could actually help perhaps predict what individuals were more at risk for intracerebral hemorrhage compared to others. Patients with CAA also have a high dementia risk conversion rate, both in patients with CAA seen in stroke clinics and memory clinics. This work is by Li Zhang, a neurologist who used to work in our group, is now high up in Sanofi and does some very, very nice work there with that French company here in Boston. And she's actually shown that CAA patients without intracerebral hemorrhage have a high dementia conversion rate, and that score that Andreas came up with, the SVD burden score, predicts that risk of conversion. So all of this is kind of falls under the larger aegis of the MARC VCID consortium. So this is a large multinational NIH-funded consortium of centers all across the US that are trying to discover biomarkers like we've done for amyloid angiopathy, more in general in small vessel disease, because this burden of small vessel disease does significantly impact whether an individual develops dementia. And so the idea around the More CID Consortium, for which we're a coordinating center run by my colleague Steve Greenberg, the goal is to discover biomarkers and then try to impact or treat these biomarkers to change the course of an individual's late life trajectory to or really away from dementia. So I'll talk briefly a little bit about blood pressure and why I think it's important beyond all this genetic stuff and all the imaging stuff that we have as in our patients. But the question is, can we do something that's an intervenable risk factor? Can we change that risk factor, or can we modify that risk factor to change the course of an individual in their cognitive trajectory? So hypertension is quite prevalent in individuals over 60, as all of you guys know. That's really the population that is at most risk for cognitive impairment and dementia. Nearly 30% of adults with a diagnosis of hypertension are inadequately controlled. And that's quite known, and it's been known for about 20 years. It's really not something that the medical profession has been highly successful at, although the reduction of cardiovascular disease in general has shown that we've been somewhat successful. But I think there's more way to go. Using the new guidelines for hypertension of systolic blood pressure greater than 130 and diastolic greater than 80, only 47% of individuals with hypertension as a diagnosis are adequately controlled. So again, there's probably a good amount of room to make an intervention here in many patients. So high blood pressure has been shown to be, of course, important in stroke and dementia and subclinical disease, but the associations between the blood pressure level and the risk of stroke, it seems to be, there's some evidence, mixed evidence suggesting that it may be reversed late in life. So individuals late in life, if their blood pressure is higher, they actually may be spared or at least have a reduced risk of dementia. And so the field is still quite open as to exactly what to do with blood pressure in older individuals. And this is, you guys may have come across this in your clinical practice too, where aggressive blood pressure control in older individuals is often not as strongly recommended as in midlife. And then the thing that we've become quite interested in is, does blood pressure variation matter? So emerging evidence from blood pressure variation studies, so there's a variety of studies that can look at blood pressure variation over hours, but using monitoring devices, days or years in different intervals, that independently contribute to stroke, risk of stroke and dementia beyond just the blood pressure level. And so the relationship between blood pressure variation and subclinical small vessel disease is a little bit of an uncharted territory, much less known. And so this is one of the reasons why we're particularly interested in this. Maybe this blood pressure variation does impact some of these MRI markers that we see on neuroimaging. And then the association of variation over years that we can follow in studies like the Rotterdam study, what the variation over years, how that impacts cognitive trajectory or clinical change in an individual is also unknown. And so now that we have technology to try to be able to measure people's blood pressures at home or more readily than just in isolated clinic visits, these questions can be better addressed. Alessandro Biffi and our group has shown that blood pressure likely has a strong modifying effect on CAA course, showing here that variation in blood pressure or increase in blood pressure after an initial intracerebral hemorrhage leads to increased risk of future hemorrhage. So, and the risk seems to be quite exponential. The higher the blood pressure one has after their first intracerebral hemorrhage, the risk of recurrence is quite high. And that's associated both with systolic and diastolic blood pressure. So, so we looked at this with my colleague Yuan Ma, who's a junior faculty and a spectacular investigator at the Harvard School of Public Health, who works with us quite closely. And Yuan has done some really nice work around this blood pressure variation and really leads a huge effort both at the School of Public Health and in our group around blood pressure variability. Yuan looked at this in a pathologic cohort and found interesting things that blood pressure variability, the systolic blood pressure variability, does correlate with atherosclerosis and small vessel disease markers, as you can see here on this plot. However, even more interesting than that, the systolic blood pressure variability was associated with neurofibrillary tangle burden. So higher blood pressure variability seemed to impact Alzheimer's type pathology in older individuals, which is really kind of a novel finding. And this was recently published, as you can see here in the Neurology Green Journal. So Yuan's work is continuing to look at this. So could blood pressure variability not only have an effect on stroke and small vessel disease, but it may actually have an effect on the neurons. So that, again, a double reason to control blood pressure and treat it well. So this is some detail from Yuan's study, really looking at this and how neurofibrillary tangles really, through mediation analysis, really mediate nearly 20 to 26% of this association, which is a very, very strong effect. So we cut this in many ways and it didn't go away. So it does really suggest this effect. It looks like it's real. So really important finding. So I'm going to just finish up with just a few last slides to kind of put everything in perspective. Kind of talked about a lot of stuff, but I want to open it up to questions. So I don't want to drone on like some kind of Harvard professor. So so let me just finish with just a few things from to help you kind of understand the breadth really of this field. This work is from my outstanding colleague Carol Brain in the UK, who's just a crack epidemiologist who's studied dementia, small vessel disease for decades. And Carol, in her group, put together this very, very nice work on dementia in populations across the globe, largely in developed societies in the West, Europe, really Europe, US, and Japan. But Craig Carroll's work here is striking in that dementia incidence across these different societies, across these different developed societies, are decreasing. It seems to be declining. And that was really started by some work that Carol and colleagues looked at in the CFAS studies. This is a UK-based study looking at elder individuals and dementia in that population over time. So CFAS-1 was done at an earlier time period, and then the CFAS-2 study followed another set of individuals later in time. And so over time, the second group, in the more modern group, as it were, had a much lower percentage of dementia, much like what Carol and her group reproduced in the other populations across the globe. And so dementia risk does, or dementia incidence does seem to be declining. And this is, again, you can look at the details here. You can certainly ask me if you want more details around this, but you have subjects ranging from Bordeaux all the way all the way to Japan. So really impressive work that Carol has and her group has done. So as I alluded to, why is dementia declining? It certainly can't be all due to hypertension, because we're not that good at treating hypertension, as I tried to show in that slide, right? The 30 to 40% of people are undertreated for hypertension. So we couldn't have done such a good job that we've really eradicated dementia, or at least reduced it. What other factors could be at play? And these are kind of these are the unknowns, as I like to often say on teaching rounds. We don't know all the factors that are changing changing us to changing what way impact our lives. But certainly our environment does play a big role in that, and the societies we live in also play a big role in that. Individuals are not unique, autonomous entities. They interact in whatever society they live or move in, and so that's important to keep in mind as I talk about this last bit. In Japan, so why do people? Japan has the oldest population in the world, really, and by the year 2050, 2/3 of the Japanese population will be over 65. So their aging curve is very much shifted to the right, and this is due to numerous reasons that I won't go into now. But if any of you are interested, I'd be happy to chat with you, because we've done some amount of work in Japan, and we have an interest in this area. But this older population, this older Japanese population, why are they living so long? So that there are probably numerous factors, but one of them may be the fact that older individuals continue to exercise on a regular basis. So this is this Raijo Taiso, which is a morning exercise routine that the Japanese government and health policy experts in the 70s rolled out to all individuals, even working in factories and working in jobs, to do this morning exercise prior to starting work. And so this is has become quite ingrained in the Japanese population, such that you see images like this, older individuals really trying to be quite methodical and rigorous about doing their morning health exercises. So could health behaviors like this impact longevity? Certainly, potentially a contributing factor. My colleague in Japan, Nenoko Tamayaya, has looked at this actually. Naoka is a spectacular epidemiologist and investigator, looking at Japanese national data, looking at these leisure activities on the activities of daily living, how functional middle-aged adults are. And Nenoka's stuff is nice in that she shows that hobbies and sports appear to have a beneficial effect. So some of these morning exercises must be important, but they seem to have the biggest beneficial effect when they're done in a social context. So so that, I think, is an important lesson, again, to say that it's not these things in isolation. It's not just the one thing that you do that is going to change your life, but it's how you do it. And Japanese individuals, if some of you know Japan, you can see oftentimes there are these social networks where people do things together. They go hiking together. Older individuals go hiking together, or they play sports together, or they listen to classical music together. That social context seems to also impact health of an individual, which I would say it's not surprising in the clinical context. If we think about it clinically, it reduces social isolation. It has other kind of unknown effects, but oftentimes undervalued, I think, in the medical consultation suite. So something to emphasize and to keep in mind, at least for us as clinicians. And then there are other things that can impact how we live. This is a sign outside of relatives neighborhood in London. What we eat actually could impact what we become. You are what you eat, as the saying goes, and so that also impacts who we are. Just as an editorial note, I would not recommend following TripAdvisor for any advice, including porridge or travel advice. So some work at the Harvard School of Public Health has looked at this, the Mediterranean diet, and how that improves cognition. This work is from colleagues internationally, shown here in this slide, and also colleagues at the School of Public Health, that suggest that cognitive outcomes can actually be impacted by what diet and that one has. A Mediterranean diet is one potential diet that could be beneficial over a person's lifetime. And this is work from Walter Willett at the Harvard School of Public Health with my colleague Alberto Achario and Bert Hoffman, have looked at dietary carotenoids as something, again, potentially associated with late life cognitive function, or preservation of late life cognitive function. So again, I think I'll wrap up here. I think the key thing is that a pill to solve all your problems is not possible. It would make life very boring. We should not be looking for it, nor watching advertisements for it. But the key is really to think about how all of these things impact our patients, and see what small changes we can suggest to our patients to help them avoid cognitive impairment and dementia late in life. So I'll finish here. This is just a summary slide, just saying who did some of this work, and some of our collaborators. And I'll take any questions if any time remains. Thanks very much for your time.
Thank you, Dr. Viswanathan. This was a really informative talk. We have a question in the chat. Stephen is asking, how do you explain the mechanism of confluent periventricular white matter disease without significant large vessel disease or microbleeds? Yeah,
so that's a really good question. That kind of, I think, falls under this larger umbrella of VCID. So there are, while a lot of these small vessel disease markers do go in hand, like I showed about the microbleeds and the microinfarcts, there also does seem to be a differential, right? So there are a lot of individuals with white matter hyperintensities, but not microbleeds. In fact, white matter hyperintensities is really the first thing we saw when we started doing imaging studies in the brain, right? And so white matter hyperintensities are exceedingly common. In the Rotterdam study, they're probably present in about 80% of individuals, and individuals with vascular risk factors have higher risk for them. But it does seem that certain individuals may have a propensity to have more white matter hyperintensities, confluent white matter hyperintensities, for example, but not the other markers of small vessel disease, or less markers of small vessel disease. Again, we haven't done a study about confluent white matter hyperintensities and microinfarcts, right? Could there be a relationship there? There probably is some types of relationships, but the arrows are weighted in different ways depending on the clinical presentation of the patient. And so that's the one other thing I'll emphasize one more time, is that and especially in this field, it really showed us, where the importance of the patient is, because all of these manifestations can be visualized. It's much like scanning the body. You're going to find things that you won't have a kind of a grounding on as to what it means. And so the white matter hyperintensities have significance really in individuals who have some kind of clinical outcome. So that's something else to always keep in mind.
Dr. Jin, stroke neurologist, asks, how would you advise the use of antiplatelet, anticoagulation, or TPA in CAA patients?
Yeah, it's a good question, actually. So, all of really kind of the short answer is that none of that is contraindicated. The longer answer is that in CAA patients with numerous microbleeds, a high microbleed burden risk, we've shown that there may be an increased risk of using antiplatelet agents in those individuals. In those individuals with CAA, those are individuals with high microbleed burden risk and a previous intracerebral hemorrhage. So that's the stroke-related CAA patients. So in those individuals, there does seem to be a microbleed dosing effect with antiplatelet agents. With the microbleeds alone in individuals with CAA who present with memory complaints, that doesn't seem to be a significant effect, at least that we can see epidemiologically. So we say that to use as normally or as medically needed in those individuals. And then finally, TPA. We don't screen and we don't do MRI screening on TPA patients routinely, but the epidemiologic data really looking at that doesn't suggest that we should be doing MRI screening to rule out CAA. So CAA patients have gotten TPA and done fine without extra risk of intracerebral hemorrhage. So no direct contraindication there.
I was just wondering if there's any strong evidence for aerobic exercise, either moderate or heavy aerobic exercise, in kind of improving the trajectory of patients with dementia. And is it part of your routine multidisciplinary care in your clinic?
Yeah, no, exactly. I think that the key thing, I'm going to stop sharing my screen here. So I can see you guys. You can see me? Yeah, and so yes, routine aerobic exercise does seem to have impacts on overall cardiovascular health as well as stroke risk and most likely dementia risk. We studied this with a colleague at the School of Public Health who's particularly interested in this area. So the key thing is frequency of aerobic exercise. And this is what I tell my patients all the time. Much like diets and all of the stuff that come on American TV, things are very, very fad-based, right? So people do things for very short periods of time and then, realize that it doesn't work over a 3-month period, and then but interpret that as it's not working in general, and stop it, right? There's no difference between that and meditation, right? So people do the same thing, right? So they do it for a couple of weeks. It's not working for me. I'm done. I'm gonna do something else. So that's an intentional disorder, right? So, but the key thing there, I try to emphasize to patients. I mean, who knows how much effect I really have, but I say, if you do exercise, it doesn't have to be super intense, but it has to be regular. And so, really, that's the key. With exercise, I find, and I'm particularly interested in this area, is that because I think it's something we potentially could make an impact on, and it's also just interesting to me because I like to play sports, is that you kind of have to have an interest in it, right? So a patient who's never done sports or exercise through their life, they come to you at age 60, you tell them to go do exercise. I mean, it's like asking them to understand Hinduism or something. It's not possible. It's just not a reality, I think. And so that's also something for us to remember, because all patients don't. It's not a one size fits all kind of a thing. It's like the pill. It's not going to save your life. You really have to. We have to really emphasize. We have to really think about the patient we have in front of us and what they're capable of, what their limits are, and what their interests are. To make the proper recommendations. The good news there is there's so many different things to choose from to impact health. So it doesn't absolutely have to be exercise, but it could be something else it's a good thing to keep in mind as a clinician.
That's a great talk and amazing research. This is Tony Wang, one of the stroke neurologists and neurointerventionists. Hi, good, thank you. What actually amazes me is that hypertension seems to be playing a central role in our life, and as you mentioned, and actually from your talk, it's striking to me that it plays important role in both the pathology of hypertensive hemorrhage as opposed to CAA, right? Yeah. So if that's true, wouldn't it make sense to consider the hypertensive hemorrhages and CAA as a actually different end of the spectrum disorder as opposed to isolated different pathologies, and treat them, in a cohesive way, right? So what's the point of distinguishing these two? Just like we struggle to distinguish between CAA and Alzheimer's, dementia. Yeah. So we're encountering the same paradigm.
Yeah, I think you're totally right. You're really spot on about that. I think almost all of these diseases represent the spectrum, and this comes from just an older generation, as you probably remember. I mean, it's in the 80s, 90s. It was really just the strong desire to kind of cut out this is the diagnosis. This is what you have. And patients like that, it was from that era too. Also, patients like that, they like to be told like you have X or you have Y, and this is what we can do about it. But in reality, as we're certainly in the brain, it's much more blurred. And I think we're going towards that in intracerebral hemorrhage for sure, right? So we've shown that also with these mixed cases with deep and lobar microbleeds. These guys are kind of in between both the deep cases and the CA cases. So it's a spectrum in reality. I think it's a really great comment. Spot on.
Thank you.
Yeah, this is Nick Palmitsakis, another stroke neurologist here. Thank you again for the great talk. In the same kind of wavelength, would it be meaningful to really differentiate between the people who have cortical microbleeds on MRI versus the ones who have both cortical, as you mentioned, and subcortical? And then maybe the second, let's say, type of patients would be the ones that we should also not be afraid to give antiplatelets, because, as you might know, many people, when they see these microbleeds and there is let's say the radiological even diagnosis of amyloid angiopathy, they say no antiplatelets, etc. So, but these people, they might have something also, as we mentioned, additional small vessel disease due to hypertension, and not necessarily the typical CAA.
Yeah. No, I totally agree with Nico. I mean, we actually wrote an editorial around this, and you can find it on our old fellow Andreas Harivindu is the first author, and I think if you put Andreas's name, I think you get every publication in the known universe. I mean, Andreas has published so much as a fellow. Has done so much work, and he's just finishing his residency now. But and the title of that paper is called "Context is Everything." So you can just put that, "Context is Everything," and it's published in, I think that it's called the Stroke Journal. I think it's in the Stroke Journal. We wrote this editorial exactly for your point, Nico. The issue was cardiologists or general practitioners were seeing this kind of radiologic diagnosis and then acting on it. And so this is why we wrote this. And so absolutely right. I think this is it's really important to put things in context. And the radiology oftentimes skews what we do.
Thank you very much. And an additional question, we don't want to take up much time, but how often do you see primary CNS vasculitis with cerebral amyloid angiopathy? Because unless sometimes you do the biopsy, you're not going to really pick this up. And we know that primary CNS angiitis has a subtype. It's a small percentage, but they have cerebral amyloid angiopathy. And obviously, these patients, they might need to be treated with immunosuppressive treatment that we use for vasculitis.
Yeah, no, exactly. Those are rare cases. We haven't really seen a lot of that in our at least in our practice. But you're absolutely right that the other associated disease associated with CAA and inflammation is this CAA related inflammation, which can resemble CNS vasculitis. And that's a subgroup that represents like less than 1% of patients with CAA, but they can get these rapid inflammatory syndromes that results in kind of reversible, but really marked white matter disease changes, and then cognitive changes and confusion oftentimes in patients, which is also treated with immunosuppressants as well. So that there's that overlap as well. And so how much of that, what we call the CAA-RI or the CAA related inflammation, how that's related to CNS vasculitis or the overlap there is not known.
Okay, thank you very much again.
Thank you, Dr. Viswanathan. Thank you for this fantastic lecture. Thank you for joining us today.
No problem. Thanks for inviting me. Feel free to reach out if you guys need anything. Again, thanks for the invites. It was really a pleasure to see and meet all of you guys. Good luck with your careers, and good luck with your next step. Let us know if you need anything.
Absolutely. Thank you so much.
All right. Take care, guys.